सर वो डन हो रहा है, लिंक भेज रहा हूँ।
I think we'll start 7 o'clock. Good evening, everyone, and welcome to the 13th masterclass of Jaipur Surgical Tutorial. Jaipur Surgical Tutorial, or JST as we call it, is an online educational activity that we started at the Mahatma Gandhi Medical College and Hospital in 2021. And this activity is looked after and coordinated by my colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery with me here in Jaipur. In the GST, Dwarka Clinic, why have we stopped recording? I think we'll wait. They probably have got disconnected. Yeah, so in JST, we conduct a regular online educational activity every Saturday morning, 9 to 10 a.m. India time. And last year, we started this masterclass, which is once in a month. It used to be last Thursday and Friday of the month, 7 to 9 p.m. both days. But recently, the IASG has started an online educational activity on Friday evenings, 7 o'clock. So we have changed the days of masterclass from Thursday, Friday to Wednesday, Thursday, so that students can attend both these activities. So today is the 13th masterclass, and the topic that we have chosen today is Pancreatico-duodenectomy and Beyond. The idea is that PD has become an almost established standard procedure with an acceptable mortality of less than 5% in high volume centers. But there are a lot of new things happening in PD, which we thought that all GI and HPB students and those who have interest in HPB surgery should know about. So that is the idea behind this, and the masterclass today will be co-moderated with me by one of our former fellows from SGPGI, Dr. Arun Kumar ML, who's currently at the Sri Gokulam Medical College and Hospital, Trivandrum. Arun hasn't joined as yet. I'm sure he will be joining soon. So I'll request him to carry forward. And since Dr. Narwaria hasn't joined, he was to talk about Lab PD. So we'll probably go ahead with the second talk, which is by Dr. Ashwini Kudari, who is again a former fellow from the Department of Surgical Gastroenterology at SGPGI and currently at Narayan Hridayalaya in Bangalore. So I'll request Ashwini to start his presentation on robotic PD. Ashwini, please.
Good evening, sir. Respected senior faculties and friends. Thank you very much for this opportunity. I'll be first sharing the literature evidence about robotic. Good evening, sir. Respected senior faculty.
Mahendra, we have started with Ashwini, so please wait some time. We will do your part later. Is it okay with you?
The literature evidence.
Yes, sir.
About,
is it okay with you that Ashwini does first, or you want to do first?
We have started with Ashwini, so please.
Yes, sir.
We will do your part.
Okay.
Okay with you?
There is some echo
Yes, sir. Is it okay with you that Ashwini does first, or you want to do first?
No.
Yes.
So before Ashwini starts, let me also. Arun, आप join कर लो, please. Yes, yes. No problem. No problem. So before Ashwini starts, let me also say that we are very happy and fortunate that Dr. Sitaram has also joined, and I'll request Dr. Sitaram to please feel free to make any comments on the presentations. Ashwini, please go ahead.
My topic is Robotic PD, review of literature, followed by a short video presentation of the same. So pancreatico-duodenectomy remains one of the most challenging abdominal operations. Even though the mortality has come down to 3 to 4%, morbidity remains significantly high, and it is to reduce the morbidity of this procedure, the minimally invasive procedures have been introduced. The classical one-stage procedure of Whipple's was described in 1935, and since then there were only minor technical modifications in the procedure. One of the transformative modification was introduction of laparoscopic pancreatico-duodenectomy by Gagner and Baum in 1994. Both of them, they described it for the first time, and they demonstrated that it is safe and feasible. Since it has
Sorry, Ashwini, you please unmute yourself.
Yeah, we lost him.
No, I accidentally muted him. Ashwini, please unmute yourself.
Dr. Ashwini, you are muted.
Ashwini? Hello?
Hello.
I'll call him.
कर रहा हूँ सर.
Yes, sir.
Yes, sorry, I by mistake muted you. Please carry on.
Yes, sir. Since the learning curve is very steep in laparoscopic pancreatico-duodenectomy, it did not get widespread dissemination. In the year 2000, the robotic Da Vinci robot was introduced, and there was a new interest in the development of minimally invasive robotic surgery, minimally invasive pancreatico-duodenectomy platform. So the first robotic pancreatico-duodenectomy was described by Professor Gillonati in the year 2003. Not able to change the slides.
Go to the exit the full screen mode.
Not happening.
Sometimes in the full screen mode there is a problem. Go back to the or maybe stop sharing and share again. Ashwini, stop. You can stop sharing once and then share again.
Is moving.
नहीं, नीचे आप वो ग्रीन बटन पे स्टॉप शेयर कर दो. It has gone back to the first slide now. या फिर स्लाइड शो से एस्केप कर लो. Yes, we are on the introduction slide. Yes, now it is moving. Yes, please go ahead.
Evidence in terms of there are I could come across 2 randomized control trials and few meta-analysis and many retrospective studies and many single institution experiences I could come across for robotic pancreatico-duodenectomy. So this is a first randomized control trial. This is called Europa trial. So it is a investigator-initiated exploratory randomized control trial with 2 parallel study arms, was conducted at a high-volume pancreatic center in Heidelberg. And all the patients who required pancreatico-duodenectomy were randomized on 1:1 basis by a centralized web-based tool. It was conducted between June 2020 to February 2022. And in robotic surgery arms, there were 41 patients. And in, sorry, this is a open
PD.
Open pancreatico-duodenectomy, there are 40 patients. This is a first exploratory randomized control trial to compare the robotic versus open pancreatico-duodenectomy. What they have found was there was a higher cost involved in robotic pancreatico-duodenectomy. Also, the operative time was high, and more number of people had post-operative pancreatic fistula and delayed gastric emptying. The other parameters mortality rates were comparable. Since it was an exploratory study, it was aimed to generate the initial insights and hypothesis rather than provide definitive conclusions. So they concluded by saying that in the setting of high volume centers, robotic pancreatico-duodenectomy can be considered as a safe technique, and for further confirmatory multicentric randomized control trials are warranted. There is one more randomized control trial. This is a multicentric trial conducted in China. Full article I could not get it, but only summary of it. It's a multicentric trial, and 81 patients were in the robotic platform, robotic group, and 80 were in open group. So after completion of the, once the surgeon gets over the learning curve, they concluded that robotic pancreatico-duodenectomy is safe and feasible with the advantage of shorter hospital stay. So these are the 2 trials, randomized control trials, and there is one more ongoing trial in China, which the results are yet to come. Results are awaited. So there is one more multicentric study comparing laparoscopic versus robotic pancreatico-duodenectomy. This is a international multicentric retrospective study, which included patients who underwent a robot or a laparoscopic pancreatico-duodenectomy from 50 centers in 12 European countries. And propensity score matching was done in 1:1 ratio. And there were 2,082 patients, and 1,006 underwent robotic pancreatico-duodenectomy, 1,076 underwent laparoscopic pancreatico-duodenectomy. They concluded that robotic pancreatico-duodenectomy required longer operative time, but there were less number of conversions to open surgery. Blood loss was similar in both the groups. Laparoscopic surgery had a lower operative time, lower rate of post-operative pancreatic fistula, delayed gastric emptying, post-pancreatectomy hemorrhage, wound infection, and it also had higher R0 resection. But the major morbidity and mortality among these two groups were similar. So this is a study from University of Pittsburgh, where they shared their experience of 500 pancreatico-duodenectomies in a 10 years time period, October 2007 to September 2017. It's a retrospective review. It is a largest single center study available till today. So it is they shared their experience of 500 robotic Whipples. So they collected patient demographics, clinico-pathological variables, and operative and post-operative outcome data. They were analyzed. Operative time was defined as length of time from incision to skin closure. That included the docking time also. So they also compared the outcome of 500 patients with the last 100 patients they operated. The average operative time. The average operative time was 415 minutes, and in the last 100 cases, it came down to 373 minutes. The conversion to open was in 5%. Effective blood loss in the first 500 patients was 250 ml. In the last 100 patients, it was 200 ml. And with time, they introduced the residents and fellows also in the operative time, and they were also allowed to do some surgical steps in resection as well as in reconstruction. Their operative time plateaued after 100 cases, and even after the introduction of residents, the operative time did not increase. And they also, with time, they included the borderline operable and post neoadjuvant chemoradiotherapy patients also, but the operative time and the blood loss remained the same. So this is and also in the second half, the number of patients who underwent vascular resections along with pancreatico-duodenectomy also increased. So they demonstrated that with the systematic approach, both the quality of the procedure and the long-term results can be improved, and they demonstrated that it is safe and reproducible and oncologically equivalent to the open procedure. There is another study from the same group about robotic pancreatico-duodenectomy with vascular resections. As you all know, that vascular resection along with pancreatico-duodenectomy is a technically demanding procedure, and it is the data says that the mortality and the morbidity is higher with those undergo vascular resections along with pancreatico-duodenectomy. This is one of the largest series which is available at present about the minimally invasive vascular resections along with pancreatico-duodenectomy. So it is a retrospective study which they did between October 2011 to May 2017. They compared 330 robotic pancreatico-duodenectomy with 50 patients who underwent pancreatic PD with vascular resections. The operative time was more, and there was more blood loss in vascular resection group, and also there was an increased conversion to open in the group. But the rate of pancreatic fistula, delayed gastric emptying, and other oncological outcomes were similar. This is our experience, which we published in the Journal of Robotic Surgery in the year 2021. It is a retrospective study where we compared 27 robotic pancreatico-duodenectomy with 29 open pancreatico-duodenectomy done at our center over a period of 4 years. And these are the results. The operative time was more in the robotic group, and but the effective blood loss was lesser, significantly lesser in the robotic arm. Our conversion rates were higher compared to the previous studies where the conversion rates are less than 10%. Our conversion rate was 28%. This is because we were going through the learning curve, and initial few cases we converted for smaller reasons. The ICU stay was significantly less in the robotic arm, and the surgical site infection was also lesser in the robotic arm. The other parameters were comparable between the two groups. And also the oncological outcome was also comparable. The total number of lymph nodes in robotic group was mean number of lymph nodes retrieved was 14. In open it was 28. So R0 resection was achieved in all patients with robotic group, and in open also 96.3, which was not statistically, difference was not statistically significant. So I would like to conclude by saying that robotic pancreatico-duodenectomy is safe. It requires longer operative time, but the blood loss is lesser compared to open surgery, with comparable oncological and short-term outcomes. Vascular resections can be done after surpassing the learning curve. Multicentric RCTs are required. So I'll move on to the video presentation. So the patient is positioned in a reverse Trendelenburg position with left side tilt, and the robot is docked from the head end of the patient. These are the port position for SI system, where 12 mm camera port is used, which is on the right side of the umbilicus in the pararectal line, and two robotic arms are placed on the right side of the patient, about 8 centimeter apart, and one on the left side, and there will be two assistant ports. So we follow the same steps in each cases. First step is opening of the lesser sac, and you see the anterior surface of the pancreas, and then once you visualize then the left gastroepiploic vein is divided. After dividing, we follow the left gastroepiploic vein downwards, and on the left side of it, that means left gastroepiploic joins the colic veins to form the gastrocolic trunk. On the left side of it, on the inferior border of pancreas, we identify the portal vein. So we do it with the harmonic scalpel. It can also be done with the monopolar cautery also. But as the cost is involved, we try to do it with one instrument. So this is the tunneling. We just identify the portal vein. We don't do the complete tunneling at this moment. It is once we identify this, you can see the clips are on the gastroepiploic vein. Below that, you can see the gastrocolic trunk. After this, we divide the stomach. This is a classical people. We divide the stomach. Once the stomach is divided, we identify the gastroduodenal artery. So, and we usually clip it. We, sometimes rarely we suture it, but we prefer to apply the hemolog clips on it. Usually 3 on the patient side and 1 on the specimen side. So the clips are being applied. After this, we proceed with the cauterization. So the cauterization has to be extensive in case of minimally invasive Whipples. It has to be more extensive than what we do in open Whipples, because if you cauterize it completely, the uncinate dissection becomes easier. So the end point of cauterization are the left renal vein or the left border of the aorta, or the identification of the origin of the superior mesenteric artery. Here we are seeing the origin of superior mesenteric artery being identified. Once we identify this, that is, we stop it, and then we divide the DJ flexure from the supracolic compartment only, and we bring the first jejunal loop upwards in this one. If you do it infracolically and divide jejunum infracolically, bringing it up into the supracolic compartment becomes a little bit difficult. After this, we take down the gallbladder, and then we identify the supracystic bile duct. We encircle it, but we don't divide it at this point of time. We divide it at the almost end of the resection part. We divide it. Otherwise, if we divide it early, then the bile will keep on flowing, and the operative field becomes stained. Then we divide the neck of the pancreas. Neck of the pancreas we divide after defining both the superior and inferior border of the pancreas. We usually divide it with the harmonic scalpel. Sometimes the pancreatic duct also gets blocked, but you irrigate with saline, it will get opened up when you are reconstructing. After we transect the neck, we proceed to the uncinate process dissection. This is the very most difficult step in the minimally invasive Whipples. This first we divide all the venous branches from the superior mesenteric vein and the portal vein. The first which we divided was the inferior pancreatico-duodenal vein. So we keep on dividing all the venous tributaries from the portal vein, and we separate the portal vein. Once that is divided, the portal vein is retracted towards the left side, and then we start to the arterial layer for the dissection. Here we can see one arterial branch. Initially, we thought it is a inferior pancreatico-duodenal artery, but once we divided that, I think we we encountered one more branch. I think the first branch was the first jejunal artery. This is the inferior pancreatico-duodenal artery being clipped. Once it is clipped and we retract the vein towards the left, and we proceed over the right side of the artery. We remove all the lymph nodes which are there on the right side of the artery. We don't expose the adventitia of the superior mesenteric artery. You can see there is a lymph node which is being dissected on the, this is on the right side of the artery. Here, the importance of the bedside assistant is very important. He has to be doing the suctioning, and he has to retract the vein. You have to have a very good bedside assistant for this step. So this completes the, we have reached the gastroduodenal artery stump. This completes the dissection of uncinate and the pancreas from the vasculage. So in the last step, we divide the bile duct. Most of the times we divide it with harmonic, but sometimes we divide it with cold scissors also. So this completes the resection part. Now coming to the reconstruction, the first anastomosis we do is a hepatico-jejunostomy, because once we do a pancreatico-jejunostomy, we don't want any traction on that anastomotic line. So first but the pattern of anastomosis will remain the same. We do the hepatico-jejunostomy first. Usually, if the duct is dilated, we do it with continuous sutures using 40 PDS. We use 2 sutures, one for the posterior layer and one for the anterior layer. Because of the, when we do a Whipple's, usually the resection takes longer time, but the reconstruction is much faster because of the magnification and articulating instruments. It is much faster than the laparoscopic reconstruction. If the duct, we do a duct to mucosa. If the pancreatic duct is dilated, we always do a duct to mucosa. Usually there will be a posterior layer with, in this case we are using Vicryl, but nowadays we are using proline, 40 proline we use in a continuous fashion, posterior layer, followed by duct to mucosa with the 40 PDS sutures. If the duct is not dilated, we have done few of the gland to mucosa type of interrupted anastomosis also. But we have not done any pancreatico gastrostomy. But nowadays, with the advent of neoadjuvant chemotherapy, radiotherapy, if the pancreas is very friable, I think pancreatico gastrostomy can become a very good option in such subgroup of patients. This is a duct to mucosa anastomosis. Once we complete that, then we do a 4th layer of pancreatic capsule with jejunal serosa. We always stent the pancreatic duct, as it is practiced in SGPGI also. So we always stent it with infant feeding tube. Then the gastrojejunostomy is anticolic with stapled anastomosis. and we pass the NJ tube also at this page. Once the stapler anastomosis is done, we pass the NJ tube for feeding, post-op feeding purpose. So NJ tube is being passed, and we close the rent with 40 PDS or Vicryl. And this completes the reconstruction part. Thank you, sir.
Thank you. Thank you, Ashwini. Arun, please take over the discussion. And Arun, unmute yourself. I may log out for some time in between. So Arun, please continue. Okay, so you can request Mahendra to do the next presentation after discussion on this topic. I just want to ask one question before I log out temporarily. So Ashwin, you had about 5 or 6 conversions. Now my point is, your analysis was done with an intention to treat. But if the conversions were at a very early stage and most of the procedure was done open, would it not be right to put those 5 or 6 cases in the open group for analysis?
Yes, sir. We have initially, when we included, it was 29 and 28, I think. And when we started analyzing, the final number was 21 on the robotic count.
Okay. Okay. Arun, please carry on the discussion.
Especially the video, and see for conversion.
Sorry, I am not able to hear.
Arun, your voice is not.
Reasons for conversion.
Reasons for conversion.
The initial 4 cases, it was bleeding from superior mesenteric vein branches. It happened in the initial first 4 cases only. We were in the learning curve, and we were very scared after seeing the blood. Once we opened, we thought that what we saw was the blood was not very significant. And over a period of time, we started using gauze to apply pressure, localize it, and hold it and clip it. The other 2 procedures were conversions were for difficult dissection.
Okay.
4 were for bleeding from this.
Okay. But generally, surgery, whether it is laparoscopy or robosystem, the magnification will be very, very large. So we feel like even a 2 cc, 3 cc blood will be appearing as huge. That is true. That is true, as you said.
And then we realized after.
Yes. Then any situations where you had difficulty when there were replaced anomalies, like replace right hepatic artery from SMA?
No, we did not have all this. One of my colleague had it, and he had to convert because he was not able to dissect out the hepatic artery from the tumor. So he had, but luckily we did not have it.
TD sir, please, questions please.
Yes. No, I was going to say that so far anomalies are concerned, I think Dr. Ashwini, we all should know in the preoperative period because of such a good CT scan available and the reconstruction pictures are also available, and we also see with the radiologists. I think for the message for the mass should be that other people or students who will listen tomorrow on YouTube or who are joining, that one should make a habit to go to the radiology department and always discuss and see the anomaly. And almost 100% time, Dr. Ashwini, I think we were there when we Raghavendran, we did thesis. Unfortunately, we have not written, but 100% times we are able to see the anomalies in the preoperative period. So that will make you wiser at the time of dissection rather than inadvertent injury. So
Even nowadays, we have the advantage of ICG on-table use for all these things if we are in doubt.
Yeah.
Majority 90, as sir said, it is detected in preoperative period only. But if you encounter something abnormal, you can always use ICG and see the anatomy again.
Dr. Mahendra.
Hello. Hi, good evening.
Good evening, sir.
Ashwini, very good presentation and good review of literatures. And sorry, I could not get chance to even review it. So I think looking at you, I think I'll also start robotic PPPT. So my volume of pancreatic surgery is much less. So I'm sticking to laparoscopy only.
Yes, sir. We are.
Dr. Sitaram, sir, please unmute yourself and discussion, please.
Oh, very nice presentation. I'm not capable of doing this operation, so I was filled with awe looking at your presentation. I saw in your specimen, you have stayed very close to the bowel. The jejunal mesentery, you don't have much jejunal mesentery excised along with the specimen. Is that acceptable today? I remember H. Ramesh saying that 50% of his recurrences were in that region. And he was very passionately advocating that we should include a significant portion of the jejunal mesentery when we excise the specimen. What are your thoughts about that?
Yes, sir. We started including the jejunal mesentery also a little bit more than what we were doing earlier. This video was recorded in the long time back. So nowadays we have started including, but not. We get scared to go to that level because everything is under traction, and if some of the vessel, if you divide and it gets retracted, it is very difficult to catch hold of it in the minimally invasive surgery. So I think we need some more experience to do that in the minimally invasive surgery.
So I have a sir, I want to just know, is it because of the lymph node retrieval in the mesentery small bowel? Why this should have more recurrence? And Dr. Harjeet has reviewed very nice this thing we were looking at him, and he is going to present lymphadenectomy extent. So probably he might be able to explain in a better way about this area, especially area in the small bowel mesentery after first jejunal branch. Does it help in retrieving the lymph node? Because resection margins are not at all in that area. Only thing is that lymph nodal extent.
Yes.
I don't know.
What about energy source? Are you happy with harmonic?
Vessel harmonic is the tip is very good for dissection also. The energy source, this vessel sealer is better than harmonic, but it is the tips are very bulky. You cannot use it for any dissection. So for that reason, we end up using harmonic more number of in more number of cases than energy, this vessel sealer.
Ashwini sir, it's a wonderful video. So I think the same point, especially in minimal invasive surgery, taking the jejunal mesentery, even maybe a 2 centimeter away, I think it's a very difficult task. So I don't know, is it how, if you are doing it, how we are doing it, whether we are doing some clip or hemolog, even, I don't know, it's really scary if you use lap and especially harmonic and you are taking jejunal mesentery. So
what we are doing, before using harmonic, we use first bipolar and seal it very well, and a little bit on the bowel side we divide with harmonic, so that the bipolar seal is there beyond the.
But I think in the post-operative you will, I don't know, this is because the long length of the area where the bleeding risk is common. So I don't know. I reviewed the literature I saw, but I did not find in literature. I did not find any advantage of doing the jejunal mesentery for the lymphadenectomy. We'll see in our presentation.
Started was we were dividing it very close to the bowel. In one of the cases, when we were going, we saw one lymph node which was on the jejunal mesentery side. It is close to the jejunal branch only. It was on that side. So we started doing little bit more than what we were doing. Only one lymph node, but if we had continued, we could have left that lymph node.
Yeah.
So that is why we started little bit more on the jejunal, not to the base, but little bit more than little bit away from the bowel.
And I think second point already discussed about the pre-operative imaging evaluation before surgery. Especially, it's very important to see these anomalies in the hepatico-duodenal ligament, because sometime when there is a stenting and sometime this fibrosis is very unpredictable in stenting. Sometimes you don't get a plane. So if you are very sure where is the artery, especially whether it's anterior or posterior, that make a huge of difference. So I think understanding anatomy before surgery, especially hepatico-duodenal anatomy, is very important in lap surgery, because you don't have a lap, or robotic surgery because you don't have a tactile sensation. So there's another point, and it's a wonderful video. Thanks.
Thank you.
Shall we move to the next presentation, please? Yes, sir. Mahendra, sir, please. Dr. Ashwini, please be with us. We will be having more questions towards you at the end of this discussion.
So my presentation is mainly on video because I just came back from Dubai today morning only. I could not even get chance to review the literature. So I'm talking about laparoscopic pancreatico-duodenectomy, and this patient is having a perimedullary carcinoma with a small lesion, and there was no lymph node on CT scan. So it was neat and clean, and a thin patient for me. So surgery is much faster in thin patient when I do laparoscopic. So I first entered the laser sec, opened up and divided the omentum, greater omentum. This is a dissection just to separate the duodenum. This is a posterior dissection till I reaches the gastroduodenal artery. You can see this is the branch. So we'll just loop it and clip it using the hemolog clip. So in this case, I prefer to divide the jejunum first and then to so duodenum is divided about 1.5 centimeter and distal to the pylorus. I always keep gauze piece, so less and less suction is required. This is cauterization of the duodenum. As Ashwini said that we should have extensive cauterization because this is most important step. So I keep doing it till I see the aorta. So you can see, we can see the uncinate here. So that cauterization is really extensive. And you can see the
Sir, I think you are not very much audible.
Hello.
Yes, sir, please.
So this is now lymph node dissection around vessels. This is a CBD, which is dissected all around and divided just below, just above the incision of the cystic duct. This was a stented patient, so there is a stent here. I prefer to push the stent inside the lumen. This is division of the pancreas. You can see that after the tunneling was done, pancreas was divided and then it is mobilized to have a better anastomotic handling. I use more of Lagasure than harmonic. This is now going to DJ flexor and dividing the first part of jejunum. You can see the stent has reached till jejunum.
Yes, sir.
So I usually prefer to do jejunal division infracolic in infracolic compartment, and then I take this mesentery of the jejunum along with it. So I'll completely dissect it. And from the same tunnel, I'll put this loop inside so that it will go just like Ashwini has shown, the loop has gone into the same tunnel and taken on this side. So this is dissection around, this is dissection of the uncinate from the portal vein. The complete uncinate process is separated. And the specimen is taken out. So this takes me around 2 hours. Then the loop is taken up. So my preference always to do a Roux-en-Y reconstruction, because I prefer to do PJ and HJ on one loop, and then I do Roux-en-Y duodenostomy so that we can feed them early. So this is creating a Roux limb, dividing about 60 centimeter beyond the loop, isolated loop which we have created, and another 60 centimeter for the Roux limb. This is jejunal which is created for the Roux limb. Again, it is closed. So this steps takes me about 20 minutes to do a Roux-en-Y reconstruction. That is maybe because of my previous bariatric exposure. And I prefer to use to close the mesenteric defect as a habit. so that there is no risk of future herniation. This is a pancreatico-duodenectomy, which is being done using a non-nuptial suture. This is Harjeet. The device which I'm using is a endostitch. So this is a posterior layer with pancreatic capsule with the jejunal seromuscular with jejunum. And after this, I placed a feeding tube into the pancreatic duct. And this posterior layer is completed after putting this tube. Then a small endotomy about 2 millimeters is done in the jejunum. And this, first I'll take posterior sutures. Now here I'm using a suture with a needle holder. This is a 30 Vicryl with interrupted sutures. These are posterior 3 stitches which are taken just behind this pancreatic duct tube which is placed. And then I'll put this tube into the lumen. So after completing the posterior interrupted sutures, I just put this tube inside and then complete the anterior sutures using the same vehicle with interrupted sutures. Since I use mainly endostitch, my speed at endostitch is much faster than the normal sutures, which I'm normal suturing with needle holders. So you can see I'm very slow at suturing by this device or needle holder. But it is difficult to suture or do pancreatico-duodenal anastomosis using a endostitch because the needle is straight. This is anterior layer. So this completes the pancreatico-duodenectomy. Then I start taking suture at the hepatico-duodenectomy. Here again, it can be done by interrupted or continuous. In this technique, I prefer to do a continuous suture. But earlier, in the initial days, I used to do interrupted. But I'm now comfortable and very happy with the continuous. And so far, I have not seen any leak with this technique.
And the suture materials are?
This is again Vicryl only.
30.
30 Vicryl, yes. So we're going on to the ankle now. And after tying the knot with this, I just applied a clip. So this completes our hepatico-duodenostomy. Now I do a duodenectomy by hands-on technique again in 2 layers. This is first layer of seromuscular sutures. This is again non-muscular suture, that is Sajidec. Now I'll open up the lumen of the duodenum. Here I use harmony because whenever there are staplers, you can't use ligasio. Again, this is a full thickness anastomosis, full thickness sutures which are taken, and that too in continuous manner. Then starting the anterior layer now. So usually I prefer to start from angle and come up to the middle. This also I have done on both sides, and my suture I'm just tying the knot only at the middle part of the anastomosis, so that angles are more secured. And one more layer after this for the seromuscular. Hemostasis is checked, drain is placed behind the SJ and PJ anastomosis. And as such, since it is isolated loop, I don't do feeding duodenostomy at all. And I start feeding these patients very fast, maybe after 3 to 4 hours after surgery. So I think because of my bariatric exposure, we prefer to have early feeding. So with this, I complete my presentation. We can have questions now.
Thank you, sir. Wonderful video. Actually, we need more of videos, right? Because sir, Kapoor sir was telling, like, today we are mainly discussing about the technical issues in the robo lap as well as open pancreatico-duodenectomies. So, questions from the panel of experts, please.
You are the boss moderator. Nobody is expert other than.
Sir, not like that. See, I have 3-4 questions to be asked, but let the experts comment or questions. Dr. Harjeet, you would like to?
Sir, yeah, 2 questions. So one is, so where you stand during surgery, all the time left, or you use leg split, or at what time during anastomosis?
My technique is always supine position with straight patient. There is no leg apart position. I always start with the right side, and the monitor is on the center of the head. So I do from both the sides, right and left. So there are 4 ports. one is umbilical port, and then two ports on either side, two subcostal and two at the umbilical level on the pararectal area. So four ports, working ports plus a camera, total 5 ports which are used. So I move both.
So maybe from the right side, you want to do a coccorization and the part of the uncinate and
dissection. Resection is done from the right side only.
All resection, complete resection.
Yes.
And anastomosis from?
That also from right side only. I rarely go, only during coccorization I may go on the left side. Not always. Most of time I can do it from right side. That is because maybe I'm doing bariatric surgery standing on the right side. I can do everything on upper abdomen standing on the right side.
And your camera person will be to your left hand side.
He's on right side also along with me. Yeah, my side only. Camera person has to be on sides.
So I think many laparoscopic surgeon, even in our center, what we practice is most of the resection is from the left side. We go between the legs. We use a leg split position, and we use the central part. Means when we are doing the tunneling, when we are doing the coccorization, and when we are doing the uncinate resection from the leg split positions. But yes, I agree. When the surgeon is comfortable in one position, he should continue to use that position. I think second is so when you are transecting the CBD, so you always use harmonic, or what is your experience with
CBD? Always harmonic.
Harmonic. Okay. Because in the initial period we had some bad experience with the harmonic, so we changed it to maybe scissors. But yes, many surgeons to whom I ask, they always say this harmonic is okay.
If we use scissor, there will be more oozing throughout, and
I agree. But sometimes we do. Now we have start putting a clip there, hemolock, and when we'll do an anastomosis, at that time we revise it. But we had initial 1 or 2 patients in which we had a leak and we bad experience, and we are assuming that probably this was because of harmonic. That's why I asked. It's a wonderful video. Thank you, sir.
So this patient, the total stay was only 5 days. As I said, we feed them much faster than open surgery. So my oral feeding starts after 3 to 4 hours after surgery. And once they tolerate for 24 hours, we can keep increasing and try to stop IV fluid as fast as possible. And I observe them for 5 days just for the leak. And we discharge the patient with drain, and that we remove after 9 to 10 days, or whenever the drain output is less than 20 ml.
Sir, one question related to this regarding port positions and all. Any lever retraction you use?
No, you've seen there is no lever retractor which was used. Only assistant is helping to retract the.
So for the benefit of students, Dr. JSB Kishore has offered 2 comments. He says that for a type 3 mesopancreas dissection, when there is a large uncinate process, especially when you are using an artery first approach, which will be a suitable approach for such cases, he says that a wide jejunal mesentery will make the oncological clearance better. Whereas if you are dealing with a small periampullary carcinoma, then adequate lymphadenectomy should be possible even without taking a lot of jejunal mesentery. I'm sure Harjeet is going to cover the extent of lymphadenectomy in the next talk. But I also wanted to ask 1 or 2 questions. So, Ashwini, if earlier, before you started doing robotic, you were doing lab?
What? Lab, only one we did, sir. We were doing only one, and from that we jumped to robotic.
I think same point.
Open surgeons move faster to robotics.
Reconstruction part, we were not comfortable. After the resection, we felt that reconstruction, all the morbidity and other outcome depends on reconstruction. We were not very comfortable. That we directly jumped to robotics because reconstruction is much
easier. I think that point is a very important point, that the advantage of robotic over lab, probably, in my opinion, I have no experience of both. I have only visual experience seeing all of you. Probably the reconstruction is much more comfortable with robotic as compared to either open or lab.
People do hybrid also, sir. Resection part, you are very comfortable with laparoscopy because change the instrument camera positions much easier than the robot, and also you have some amount of tactile feedback is also there. How much you are retracting, how much force you are using. In robotic arm, sometimes when we are retracting duodenum, sometimes when there is some stress increase, sometimes injury to the duodenum also just by retracting. You don't know how much force you are using, sir. That feedback.
Is anybody using this approach that you use lab for resection and robot for reconstruction in the same patient?
Yes, sir, they are using, sir. Many reports are available in the literature where they use lab for resection and reconstruction. The main comes in reconstruction part for the robot.
So maybe we can take 2-3 more minutes to address this issue which Harjeet was trying to ask Mahendra about the position of the surgeon. So Harjeet, what is your approach? You stand between the legs? Unmute yourself, please. Unmute.
Yeah. So we use a leg split position, and we start our dissection from the left side. So major dissection is from the left side. So when we find it's easy when we are cocorizing, we shift our camera from umbilical port to the right. We put a right paramedian 12 mm port. So we shift our camera to 12 mm port, and then we'll do cocorization part from the in the leg split position from the center of the between the legs. So then we again shift to the left side. So after doing all hepatico-duodenal dissection and everything, so when it's a part of neck transection and uncinate process, then we again come to the between the legs for the uncinate resection and the pancreatic neck resection. So majority of the time is from the left side, but sometime is between the legs.
But so in the leg split position, would you ever stand on the left of the patient?
Yes, sir. Most of the time on the left of the patient.
So I think Harjeet, try on the right side, you'll be more comfortable. Believe me.
So again, both of you, for the benefit of students, please explain what steps are better done from right side, what steps are better done from between the legs, and what steps are better done on the left side, standing on the left side of the patient. Because I'm sure with both your approaches, the students are a bit confused as to which is the best position. So Mahendra first.
For me, I think everything is possible from right side because that is what I do. All my upper GI surgeries, I always do it from the right side. That is because of my routine habit. But I feel only transection and dissection, tunneling will be very good from the leg apart position and when we are standing in between legs. So you are dissecting straight and you're transecting the pancreas. So that is the stage where I think the leg apart is useful. Otherwise, most of things can be done. And from the left side, if you want to do the cocorization supracolic supraduodenal part is very easy from the left side compared to the right side. But as I said, I can do it from the right side as well.
So Harjeet, when you use the leg split position, when do you stand on the right of the patient? When do you stand in between the legs, and when do you stand on the left side of the patient?
Sir, I never stand on the right side. So I start dissecting from the left side. So I open the gastrocolic omentum. Then we identify the ileocolic vein. We go to the uncinate process. We go to the inferior border of the pancreas. We identify the SMV. At that time, once we see the SMV, we mean junction of ileocolic vessel with the middle colic and formation of the SMV. At that time, we shift to the between the legs. At that time, there we tunneling is done from the between the legs.
So you are never standing on the right side of the patient.
Yes.
And you said right side only camera shifts from umbilical to the right paramedian.
Right, when we are doing the cocorization, because at that time we feel the vision is very clear, because in lab you need a very good extended cocorization. So I think at that time the camera is in very good position when you are using the right median port.
Harjeet, are you using 45-degree or 30-degree camera?
30-degree, sir.
Start using 45-degree, you'll have a helicopter view and you'll have better vision by the 45-degree. Believe me, that is very, very important.
I've seen one Korean surgeon operating from the right side and very nice dissection he did, but I tried once, but maybe we are used to from the left side. That's why it's very difficult to do experiment in lab. That's why we did PD. That's why, but definitely will.
My steps, and you see that every step I'm doing from the right side, even all suturing.
Okay. Arun, we can carry on, please.
Sir, any more questions from TD sir?
Professor.
My only question would be about using two loops. Lots of report available about open pancreatico-duodenectomy, and there has been no advantage of the two loops. Regarding, just listen please first. Regarding the oral, there are people who are nowadays feeding gymnasty has been stopped in multiple centers, and then oral starting, and if you see the SGPGI discussion also orally starting and FJ causing more gastric ileus. But yeah, then oral can be started. In certain patients where you will have a complication, the only fear is when you have a complication, like you have a leak and like you have a ileus, then your feeding anatomy becomes a lifeline. And probably because we are in a country where our affordability of the patient, especially when center we are working, all pure people come, and suddenly when you need a TPN to salvage the patient, then it becomes very difficult because people are not ready to accept that. Otherwise, because you are having your good results, so reconstruction is always debatable. So you can you are having good result. That is what we always say, that people who are used to the any procedure, if you are having good result, so you should use. But we should also know other procedure, because when you are in trouble, then probably your rescue procedure also we should be knowing. That is what.
I totally agree with you, and I followed you as well. So this is what I started 25 years ago when I came to private practice. I started doing this isolated loop, and I'm very happy with the early feeding. So, and even if they develop gastroparesis, we can always put a tube. We can put the tube in the jejunum and start early feeding, if at all it is required. So. Yes, your point is well taken, but since I'm comfortable doing this, I'm very happy, and since my numbers are very less, I don't want to modify my technique.
Yes, that's why I'm not saying. That is what I'm saying for the people listening, that this is also upcoming now, that oral can be started early. And I'm seeing this paper. If you are seeing multiple papers nowadays, people are not using drains also. But because of the evolution of the intervention radiology, so suppose tomorrow you have problem, you are putting a pigtail. So people are saying drains are not required. It might be producing more and more infection. So that is how science has evolved. And probably these are the things we are very much used to FJ by feeding gymnasty because of the type of circumstances you are doing. And as you said, somebody used to, you don't want to take a risk, and the patients are very comfortable. Next day FJ started. Even say in the evening also we start FJ in the evening when you are doing FJ. And then next day we try to go up, because as you say, as I have already said, that our patient in government is not very well-to-do, and usually they are not. Nowadays, Dr. Harjeet, we started lots of rehabilitation, trying to optimize. Still, there are multiple issues with the patient. But if your result is good, then it's all okay.
In my patient, only problem which I faced, the only complaint which I faced in post-op period was a pseudoaneurysm bleed, which required angiography and stenting of the hepatic artery.
That has happened with everybody. For the Laparoscopic, once upon a time it has happened, and it has been salvaged. That's okay.
Sir, just a comment. TD sir, kindly excuse me. I may join Dr. Mahendra on this side regarding isolated rouleum. 12 years back, similarly, when I also started doing Whipples and starting my private practice. Initial one patient had a pancreatic anastomotic failure. After some time, it became a total mess. Like patient had feeding gynostomy, but HJ leak, GJ, I mean, it was a very, very tough situation. So probably that time changed to something like an isolated rouleum. So maybe we don't have much evidence on this, but still the philosophy or the policy behind such a decision, such a dramatic decision was, whatever HJ leaks or PJ leaks happen, it will become a controlled external fistula. so that it won't interfere with the GI continuity, so that your patients can be fed orally. Even this PJ leak or HJ leak, if it is high volume, that drain bile can be refed through a feeding geonostomy or through orally or something like that. So probably after that, I mean, it adds something like 30 minutes, the 45 minutes extra to our surgery, but the leak rates and anastomotic failure rates were less. So I don't know for what reason, but still our units for the last 12 years have been following this. PJ, HJ in the first loop and an isolator ruling for the gastro. Even though all I learned from all my teachers that like SCPJ, Trivandrum Medical College, HRMS unit Kochi, all the three units I learned Whipples, but everywhere it is PJ, HJ and GJ or duodenectomy in succession in the same limb. But there are certain areas where we try to deviate, and this is one of the modifications. I don't know, it is really working well for us.
No, it's as I said, if you have a result, that is what happens. Suppose you had a drop setback, and then the one thing I would like to say, Arun, that
Sir.
if sometimes there is a pancreatic anastomosis failure, it kills all the anastomosis, and it happened with us once upon a time, and it's very difficult to salvage the patient. But I am not sure whether adding one loop can salvage, but that is what which has happened. So as I said, we have about 68 reconstructions, and all of them are people are using one or another. And for the people who are listening, that once, as I said, once you are comfortable with one, you can carry on. There is no RCT comparing one to another. So
Yes,
that
sir.
is good. Okay.
Sir, shall we move to the third talk today? Yes, please,
Yes,
Dr.
yes,
Harjeet.
please.
Yeah. Yes, Dr. Harjeet, please.
So my screen is visible?
Not yet. Please share your screen.
Share
Share on the screen.
Dr. Mahendra, you stop sharing, then he can share. आपका आवाज नहीं आ रहा महेंद्र, आपका स्क्रीन शेयर बंद कर दोगे, देन डॉक्टर हरजीत कैन शेयर.
Stop sharing long back.
ओके, अभी आया नहीं डॉक्टर हरजीत आपका स्क्रीन.
Dr. Avinash, can you please help with help Dr. Harjeet for screen sharing?
Yes, sir.
He is co-host, so he can share it.
No, sometimes there is a problem in this Zoom, no?
If it is taking some time, can I ask just one more question? We have seen Dr. Ashwini doing classical Whipples and Dr. Mahendra doing pylorus preserving. Any quick comments or thoughts from any of the panel, any of the experts here, please?
Now it is Dr. Harjeet, it is coming, it seems. Yeah.
Yes.
Okay, thank you.
Yes, it's slowly visible.
Yes.
It's okay?
Yeah.
अपग्रेडेड आ रहा है आपको, वो आपने खोला है? Have you opened your presentation?
Yeah, now. Is it
Okay.
visible now? Presentation is okay?
Presentation of white screen is visible.
White
Okay,
screen.
just wait.
TD sir, what do you do? Classical or pylorus preserving?
So I am not doing laparoscopy. Harjeet does it, and only when I'm in problem, I do this thing. One thesis we did a pyloric ring exclusion with Dr. Vikas. Otherwise, I do pylorus preserving. And
Okay.
when there is any issue, sometimes duodenum gets a little bit more devascularized, then only. Otherwise, my choice is pylorus preserving.
Dr. Ashwini, you do classical always?
Always classical.
Always classical.
He's a classical surgeon.
Sir. Sitaram sir, what are your thoughts? Just a quick comment regarding pylorus preserving versus classical.
I think reconstruction for me is easier.
I think there are two things might have opened. अब वो एक बार आप देखिए कि कितने वो open है, उसमें ये आ रहा है इसके.
Now is it okay?
No.
ना,
No.
अभी जो आ रहा था ब्लैंक वो भी बंद हो गया.
नहीं, जूम दिख रहा है, तो जूम आ रहा है. जूम की
Zoom आ
Zoom
रहा है.
आ रहा है ना? हाँ आ रहा है. Okay.
जूम की विंडो आ गई, बट
Now
same.
it's visible.
No, only Zoom window is seen.
Okay, but
Maybe you.
so I will stop sharing again. I will share again. No? I will stop. Is it visible now?
Yes.
Yes, better, please.
Okay. Thank you.
All Chandigarh is.
Sorry.
No
So
worries.
there's something happened with my Mac. I think there were some security issues. So I'm sorry for this.
Yes.
So first of all, shall I start?
Yes, please.
Okay. So first of all, I want to thank Professor Kapoor and Jaipur Surgical Tutorial team for giving me this opportunity. And good evening, everyone. So after seeing the wonderful demonstration of the pancreatico-duodenectomy by robotic and Whipples, so now we'll discuss. So what should be extent of lymphadenectomy when we are doing a pancreatico-duodenectomy? So as we all know that pancreatico-duodenectomy is a complex surgical procedure and associated with a lot of morbidity, and but this procedure has evolved over a year. So, but still the optimal lymphadenectomy in pancreatico-duodenectomy is disputed. So why is disputed? Because if you see the literature from the Whipples was started, there was a different nomenclature used, different definition used, different classification used for the lymph node stations and type of lymphadenectomy. So that means it's very difficult to compare. Even a surgeon which is saying I'm doing the standard lymphadenectomy and the other surgeon is doing the standard lymphadenectomy. So these lymphadenectomy may be different between the two surgeons because of the difference in the nomenclature and the classification. So it is very difficult to compare the two studies when they are few years apart. The second thing is surgical technique may differ between the surgeon and center. So we are using the same name for the lymphadenectomy, but actually the surgeons are not doing the same lymphadenectomy. So the outcome is very difficult to compare. The standardization of this procedure in the form of lymphadenectomy is, Whipples has been standardized everywhere, but for lymphadenectomy, it is not achieved across all the centers. The second difficulty is the adjuvant treatment, because over a time, the different adjuvant treatment has been used and different type of lymphadenectomy has been used. So these are another biasing factors in comparing the actual role of lymphadenectomy in the survival of pancreatico-duodenectomy. So for the nomenclature issue, the Japanese Society of the Pancreatic Surgery, they tried to devise a nomenclature for peripancreatic lymph node in 2003. So the nomenclature is almost same as we use in the gastric malignancy, but it is very important to understand this nomenclature. So let's revise quickly. The station 7 is the left gastric. Common hepatic artery is divided into two, that is 8A and 8P. 8A means anterior node, 8P means posterior node. Celiac axis is 9. Splenic hilum nodes are station 10. Splenic artery are divided into two, that is proximal is 11P and distal is 11D. Hepatico-duodenal lymph nodes is important to understand. 12A is along the artery, 12B is along the bile duct, C is along the cystic duct, P is along the portal vein, and H is also described in the hilum. Very important node station which is important for the pancreatico-duodenectomy, the station 13 is, these are the node which are retropancreatic behind the pancreatic head. SMA node is along the station 14 is lymph node along the SMA. Aortic cable is station 16. The another station which is important is the 17, which is anterior lymph nodes. on the anterior surface of the pancreas that has been labeled as 17A, which is more superior, and 17B, which is more inferior. The lymph node along the inferior border of the pancreas are classified as 18, which is usually not a part of pancreatico-duodenectomy, but can be used. These lymph node stations are important when we are doing the distal pancreatectomy. So see this heterogeneity in the nomenclature of lymphadenectomy. So these are the 4 major trials which compare the standard lymphadenectomy and the extended lymphadenectomy over a different period of time. Here you can see in the standard lymphadenectomy, the lymph node stations are different between the different studies. So the outcome is very difficult to compare between the 2 studies. Similarly, in the extended group also, the lymph node stations, they are not similar between all 4 studies. So they are different for the different studies. So then, because there was no standardization, so then efforts was done by the international study group of the pancreatic surgery in 2014. The experts sat together and they made a consensus statement, and they defined what is the standard lymphadenectomy in pancreatico-duodenectomy. So this is applicable to both pancreatic tumors and the periampullary malignancies. So we'll discuss what is standard lymphadenectomy in pancreatico-duodenectomy. So we'll discuss one by one these nodes, how important these nodes are. So station 13 and station 17, when this consensus was made, there was no dispute on these lymph nodes. So all agreed because these lymph nodes are the part of the specimen. So these lymph nodes are the anterior, along the anterior surface of the pancreas is the 13A and 13B. And along the posterior on the posterior surface is the 13A and 13B, and on the anterior surface is the 17A and 17B. And these are most common nodes. Around 40 to 50% of the positivity is seen in these nodes only. The second group is the important group is the SMA node, that is called the station 14. So they are divided into 14P. P means proximal nodes and D means distal nodes. So in the advanced tumor, this is the most common site of recurrence. This uncinate part is the most common site of recurrence. And in standard lymphadenectomy, the standard dissection should be, as Dr. Ashwini and Dr. Narwaria showed, that it should be along the right lateral side of the SMA, no circumferential dissection. Definitely it is associated with increased morbidity and there is no survival advantage. So this is one clip which we did, which I'm showing for one of our patient who underwent a periampullary, case of a periampullary tumor and underwent a pancreatico-duodenectomy. So all resection has been done. So this is a part when you are saying this is the SMV, this is the formation of the portal vein. Here you can see this is SMA, this is mesopancreas, and this is the uncinate process. So we'll see how we take this node. So here you can see the IPD has been ligated, this clipped. So we are going along the right border of the SMA, and here you can see all the tissue are taken along with the specimen. So here you can see this is SMA, here is a mesopancreas, and this is ligatic IPDA. So this should be our dissection plane. The right wall of the artery should be seen. So this completes all station 14 lymph node dissection. So the another station is a celiac axis. So in routine lymphadenectomy or standard lymphadenectomy, there is no role of celiac axis lymph node dissection. Another important lymph node station is the station, the lymph node in the hepatico-duodenal ligament. Basically, in the hepatico-duodenal ligament, the lymph node stations are station 12. 12 means those stations which are close to the CBD and the portal vein. And the distal location of the hepatico-duodenal ligament is the station 8. 8 means along the common hepatic artery, suprapyloric and the infrapyloric lymph nodes. So why I combine these lymph node together is because when we do a lymphadenectomy in pancreatico-duodenectomy, we take these lymph node usually together as a part of specimen. So what that consensus statement said is that standard lymph node in HDL should include station 5 and 6. So it is little bit disputed 5 and 6. In some studies, they don't take it as a part of standard lymphadenectomy, but in this consensus statement, they said 5 and 6 should be a part of standard lymphadenectomy. 8A means only anterior lymph node along the common hepatic artery. 12P B, lymph node along the bile duct, and C is along the lymph node in the area of cystic duct. So there is, in standard lymphadenectomy, there is no role of 8P dissection, 12A or 12P, means no dissection around the portal vein or along the arteries. So what should be upper extent of lymphadenectomy when you are doing the HDL dissection? The upper extent is where this is the right hepatic artery. So these are the lymph node station which you are supposed to take. So this is the right hepatic artery. So you are supposed to take everything below the right hepatic artery. So your upper resection limit is the right hepatic artery. So this is a small video clip of the same patient which is showing the station 8 dissection, lymph node station 8 dissection. So here you can see this superior border of the pancreas. So this is the CHA lymph node. So we are dissecting over the common hepatic artery with the bipolar scissors. So here you can see the whole tissue along the anterior to the common hepatic artery is taken. So CHA node. So this is all lymph nodes along the common hepatic artery anteriorly. So usually we don't loop the common hepatic artery and don't do the posterior dissection along the common hepatic artery. So after this lymph node, your CHA is clearly visible. Now it's very easy to dissect the GDA. Once you have seen the CHA like this, then you can clearly see the GDA and you can clip it and ligate. So then your dissection, once you have done the CHA dissection, since CHA lymph node dissection, you have ligated the GDA, then your dissection goes to the hepatoduodenal ligament. So here we are in the HDL. Here you can see we are dissecting the calyx. So you are supposed to take, so this is lymph node at the cystic duct. So you are supposed to take this lymph node along the specimen. So maybe towards the gallbladder side or towards the specimen side. So the CPD has been looped. We are using ICG for the better identification. So this is the GDA. There is another patient in which we are ligating the GDA. So once the GDA is ligated, here you can see that we are taking all the tissue. This is all the tissue from the right of the portal vein towards the specimen. So this is, here you can see this is the portal vein. So the CBD, the upper end is we do temporary clipping of the CBD so that there should not be any bile spillage. So here you can see all the lymphatic tissues and all the lymph node has been taken along with the CBD with the specimen. So this is the clearance of HDA, means 12P, 12B, 12C, 8A, and in this patient we did a classical PD. So 5 and 6 is also included into the specimen. So this is what a standard lymphadenectomy in pancreatico-duodenectomy is. That's already discussed. Station 12, station 5, station 6, 8A, station 13, 17, and station 14 only on the right side of the SMA. 8P and 16A is debatable, so I will not go into that debate, but we can discuss if there will be a time. So what is extended lymphadenectomy? Extended lymphadenectomy is we do what is done in the standard lymphadenectomy. Other than this, the common hepatic artery is, we also include 8P in extended lymphadenectomy. Celiac artery lymph nodes are also dissected in extended lymphadenectomy. Superior mesenteric artery, both you are supposed to do the circumferential dissection in the superior mesenteric vessel when you are planning the extended lymphadenectomy. All the 16 lymph nodes, 16A and 16B, means paraidiotic lymph node from celiac axis to IMA. Skeletonization, we just dissected the, in standard lymphadenectomy, we dissected the lymph node along the bile duct and the cystic duct, but here you are supposed to, in extended lymphadenectomy, you are supposed to skeletonize everything, means artery, bile duct and the portal vein. 12A artery, B is bile duct, and 12P is the portal vein. So other than this node, what makes lymphadenectomy, extended lymphadenectomy, is the nerve dissection circumferentially along the vessels. So you are supposed to dissect along the CHA and SMA, and you have to bear it completely from the nerve tissues or the nerve plexus. even in the standard lymphadenectomy, in many studies, the only semi-circumferential dissection of the celiac axis has been described on the right side. So after this, I will be discussing few trials and studies which will highlight that what should be an ideal lymphadenectomy in pancreatico-duodenectomy. So these are the prospective study, but these are the non-randomized trial. So here you can see there is a one trial which was published very early, did not show any advantage of doing the extended lymphadenectomy, but there was another trial which showed advantage, but in this trial, the chemoradiation therapy has been used. And the another three trial, they favored that the extended lymphadenectomy is beneficial in patient with a pancreatico-duodenectomy. So still with these studies, there is a debate. So then there was a, till now, I searched the literature, till date, there are 5 randomized trials which has been published in the pancreatic tumor between standard and extended lymphadenectomy. So this is one of the trial in 2015, which was published from the Mayo Center from USA. They compared the standard lymphadenectomy with extended lymph node dissection, and 49 standard versus 39 extended lymphadenectomy. Lymph node harvesting was definitely better in patient who had extended lymphadenectomy, but in this study, there was no significant difference in the major morbidity in patients between the two groups. But what they found is this is a survival curve. They did not find any significant difference of overall survival in patient who underwent the extended lymphadenectomy. This is another trial. Long-term results of that trial has been published from the Japan in 2012, which is a multicentric trial which compared 51 patients with a standard lymphadenectomy with the extended. And again, the lymph node retrieval was definitely better in extended, but and post-operative morbidity and mortality was similar, but severe diarrhea was more common in the extended group. If you'll see the survival analysis, there was no significant difference in the disease-free survival and overall survival between the two groups. They also compared patients who had a node positivity and node negativity. Even the node positive patient did not show any survival advantage in patient who underwent the extended lymphadenectomy. This is another trial which was published from Korea, in which 83 patients of the was compared with 86 patients. This is the lymphadenectomy what they used in their study. Here they used in standard lymphadenectomy, they used the 12B and 12C, station 13 and station 17. So in this trial, they did not included 5 and 6 as a part of standard lymphadenectomy. In extended lymphadenectomy, all lymph node has been harvested and the celiac and SMA plexus only right side of the artery was dissected. So if you see the survival analysis, there is no significant difference in survival between the two. If you compare the extended versus standard, there is, even in the node positivity, those patients who had a node positivity did not show any significant difference. But the difference was when they did a standard lymphadenectomy and when they used the adjuvant treatment, the survival was much better in patients with a standard lymphadenectomy and adjuvant treatment. And there was no significant difference when the extended lymphadenectomy has been combined with the adjuvant treatment. So the meta-analysis of many randomized trial and prospective trial did not show any significant benefit of doing the extended lymphadenectomy in patients who are undergoing the pancreatico-duodenectomy. Routine pancreatico-duodenectomy. I did not deliberately discuss the borderline resectable tumors or because I think that talk will be covered by someone else tomorrow. So there is no significant long-term survival in patients who underwent extended resections in pancreatico-duodenectomy. So with this, I conclude that the standardization of the nomenclature of a lymphadenectomy is important for the accurate comparison between the studies. So none of the studies showed that the extended lymph node dissection along with the now plexus dissection had an advantage of survival. So there was no major difference in morbidity, but definitely the morbidity is little more with the extended lymph node dissection. And the last trial showed that if we'll combine the standard lymphadenectomy with appropriate adjuvant treatment, that improves the survival. Thank you.
Thank you, Dr. Harjeet, for the wonderful, very crisp and I mean, it was very nice, especially the presentation of data and everything. Very nice talk. And questions from the panel, please.
So, Harjeet, please correct me if I'm wrong. For the benefit of students, the HDL dissection for pancreas is not same as gallbladder, because in gallbladder we go right up to the hilum and everything is skeletonized, isn't it? So there is a difference. This question is often asked from the students, that what is the difference in the HDL lymphadenectomy between, say, gallbladder or cholangiocarcinoma versus PD. So PD, as you rightly said, it is mainly on the anterior surface of the CBD and hepatic artery and caudal to the level of the right hepatic artery. We don't go behind the portal vein.
We don't go,
Okay. Now this, although we will discuss this tomorrow, but when you say that you are doing only the lymph nodal dissection on the right surface or the right border of the SMA, so what is the difference between this and what we are going to discuss tomorrow in the new philosophy or the new technique of arterial divestment?
So in arterial divestment means we are dissecting onto the SMA. So you are supposed to loop because first of all, the aim is to get a R0 resections. So that's why we are doing the artery first. So I think the dissection is definitely different. You are supposed to loop the supramesenteric vein. You are supposed to loop the SMV, or sometimes you need a resection of these vessels. So we are going into the plane where, because there is a lot of tissue on the SMA, the nerve plexus and everything, there is a lot of tissue. So we are supposed to dissect onto the tissue to bear the SMA completely. And sometime when you're bearing this tissue, you are supposed to go, because that's how it has been explained, different level 1, 2, and 3, depending upon the involvement of the uncinate and the involvement of the tumor. So in these, we do dissection onto the SMA, we do a nerve plexus dissection, and we bear the artery completely. So here is only, I think, the right part. We don't loop the SMV, we don't loop the SMA.
A philosophical question which maybe you can take, or maybe Dr. Sitaram or Dr. Yadav can also take, that when we say that we are doing lymph node dissection of a particular group, how can we say that we will do only the right side and not the left side? They belong to the same group. So does it have any scientific basis, or it is more for logistics, it is more for technical ease, and it is more to decrease the complications which are associated with divestment of the SMA in terms of neural and lymphatic complications?
Sir, yes.
Go ahead.
No, sir.
So I just wanted to say, sir, initial reports by Ishikawa, and he described total bearing of the SMA, and basically in a patient where it was a pancreatic head tumor, not the periampullary tumor, and because of that, going and taking all the neurovascular bundles from all around the SMA, it was found to have a lots of diarrhea. And patients were subjected to TPN and some sort of sometimes even acute right. And that's what the big comment given for his technique. Second person, which is Japanese, I am forgetting the name. He was president of the our association of APH PBA. He used to take SMA and resect and then dissect. But this part also has lots of problems in the post-op. So when we are talking about what Dr. Harjeet is saying, we are talking about usually first is that most of the lymph nodes are present in that area. And when we are doing only on the right side, we are talking more of the uncinate process and trying to have the margin negative in a pancreatic head tumors. But if you are going toward the left of the SMA, in between the SMA and that particular tissue, some people come from left to the right. but to have the same type of outcome. Then obviously a whole neurovascular bundle is taken off. And that's why probably more and more diarrhea. But the first article, I think Dr. Harjeet covered all the recent, but when I was probably registered, then first RCT was done in Hopkins only. Extended lymphadenectomy vis-a-vis standard, and
98, yes.
they could not find any difference in the survival in a pancreatic head tumor. So we are not talking about periampullary, where you don't need to take all the tissue away from the SMA.
So one more question.
So I think,
yeah,
sir, I think it's a very valid question, because I think in SMA dissection, so why we are talking about the right side only, I think maybe is actually a lymph node, or whether it's an attempt to achieve a R0 resection. So maybe when you are, because why we are saying because ultimately why recurrence is there, because the uncinate tumors, which is in close proximity to SMA, if it will not go till the supramesenteric artery, there is high chance of recurrences. So I think by saying so that you do all the lymph node dissection along the right side of SMA, means once we are achieving the lymph node clearance on the right side, second we are achieving the better margin on the SMA. So I think that's why I think this has been described there. You do this resection, but definitely if the lymph node involvement is there, and then whether we are converting into the survival advantage, that's we are not sure.
Dr. Sitaram wants to say something. Dr. Sitaram, please.
Sorry, I didn't want to say anything, but since you asked, no, I think the right side of the superior mesenteric artery, I think philosophically that was reached by saying that you can't go beyond that, because you can't take the superior mesenteric artery. So you stop with the right side of the superior mesenteric artery. But I think if you have nodes right or left in the region of the superior mesenteric artery which have tumor in them, that patient has gone beyond the limits of this operation. You can't cure that patient with this operation. I don't know whether I've expressed what is in my mind.
Sir, one more important point. I think we should also understand the anatomy of the uncinate process and where its mesentery is going and inserting. So if you see the anatomy, three different types of insertion of the uncinate in the retroperitoneum. So one just reaches the most easy one for the surgeon, and everybody reaches, and that to the right of the SMA. Another goes behind the SMA, and third part, which is the most complicated, what probably Dr. Kishore conveyed, it goes beyond even to the left of the SMA, and that pancreas has its congenital vascularity coming from the SMA, and because of that, probably it has its lymph nodal presence also in that particular area. So that's why probably, and obviously commonest one is type 1 insertion. So probably that's why taking in a head of pancreas tumor, taking that particular part going up to the right of the SMA suffices. But when it type 2 and type 3 is there, especially type 3 is there, then probably encircling the SMA and trying to take the lymph node. So maybe a huge, but I have one experience. I removed the specimen, and then I found a node on the left of the SMA in one of the father of my student when I was in government medical college, and this I did in PGI. Then I had to remove the lymph node after my resection, and patient received adjuvant, but he is surviving. So probably lymph nodal dissection, that was positive. Sorry, that was positive also, sir. So positivity, since after removal, before removal, I could not realize that there is a lymph node. But the moment we removed the specimen, we realized that there is a nodal tissue. So since everything was in front, I dissected everything off. So these are the probably reason. That's why right is more and more described, because of the mesopancreas. More important is mesopancreas insertion, which probably by any anatomy we are not able to see, except that you while doing the operation, we find that mesopancreas is going inserting in the retroperitoneum, crossing all the way behind SMA and left of the aorta also. Sometimes is good. Then we call para-aortic lymph node, which is usually supposed to be not curative resection once it is involved.
So, sir, I don't know whether your removal of that lymph node helped in survival of this patient, or removal of that removal of node and better stagings. Maybe I don't know whether other node was, so that means we have staged it better. Means we know it's an N1 disease and we give adjuvant treatment. So that's why I'm saying it's very difficult in literature to say that whether it's only node which improved the survival or it's a better staging and then adjuvant treatment which ultimately resulted in the better survival.
Biology also, maybe location, and that's why tumor was that area. Biology also. So all these factors are important. But as I said, suppose I would have palpated and node was not that before operation, I would have hesitated in doing pancreaticoduodenectomy. But once I removed the specimen, I saw that lymph node. So we went ahead and did it. So all these things, as I said, had largely, but we are not doing that meticulous this thing. But you also remember that after that, I met our pathology department and we did that margin in pancreaticoduodenectomy with the Mohan. We did one thesis also. Yes,
one practical question, sir.
Yes.
Sir, one practical question, but regarding the practices, do we have a regular system of separating all these stations, lymph nodes, once a specimen is out and sending them separately for histopathology, or the entire specimen in toto is sent to the pathology, just individual units? Because what we do in our practice is, if a new pathologist, if a system changes there, the first 5 or 7 ripples we go to them. We talk to them, we discuss the grossing, and we be with them during grossings. We will, orient the specimen anatomically and tell them these are all the stations required. Otherwise, we don't actually do a separate, 5, 6, 12. We don't remove it separately. And I don't know what are your practices, sir?
So we take lymph nodes like suppose CHA is coming separately, we do take it separately. So node which we are taking separately, we label it separately and we send it separately. But after resection, we don't ourselves do the specimen dissection and we don't separate the node. And even we, in our pathology department, is a very big department, so it's very difficult to teach it and everyone. So thus we have to rely what they reported. So in our center, we don't practice this, but I think that's the ideal way you did it. So that it should be done. But in our center, we are not doing like this.
No, we are not separating the lymph nodes. We will just
but you're teaching
but
you're teaching your pathologists also because it's important. You have to tell them what is the important is these nodes and how to dissect it. And maybe I don't know, in our department, maybe a junior most person is doing the grossing of the specimen. So that's very important. The grossing of specimen is very important when you are really want to see the staging and lymph nodal involvement.
So, Dr. Arun, I was with Guru Handa for some time. So I saw a person who has operated. He will go to the pathology department next day in the morning and sit with the pathologist and tell these are the areas we want to, as you said, but obviously we have not done. But I think Dr. Asim Das, when we discussed with him, he made a little bit of a standard, because nowadays when we are getting our reports, then they describe all the margins very clearly. This margin, otherwise earlier they were not doing it many.
Even margin they were not doing.
Margins were not there.
But now the margin they are very clearly saying.
Very clearly they describe.
They are clearly describe all the margins.
Unless we mark the margins in the specimen, once it is put in formalin, it is virtually impossible for the pathologist to know which margin is what. So either we ink or we put separate sutures, long, short, single, double, whatever. And all those details have to be mentioned by the resident in the requisition form. And ideal, of course, is that you discuss the specimen with the pathologist, but it's important. But again, I think in most centers, majority of the resections are for periampullary, where probably margins are not that important. But in head, pancreas, or in uncinate, it definitely becomes important.
In South, it's more important, sir.
Okay, yeah, CP. So we have 2 more minutes. Arun, any concluding comments you would like to make as the moderator?
Sir, the first talk, we saw a beautiful video of robotic pancreatico-duodenectomy, very well narrated, all the important things, and the graduation from open to robo-assisted Whipples, we have seen from Dr. Ashwini Kudari. Then moving on to Dr. Narwaria, a beautiful video, almost all the steps in detail, the suturing techniques, focusing more on the technical aspects. We have seen the entire spectrum of laparoscopic pancreatico-duodenectomy. And the third one from Dr. Harjeet, we have seen actually he exposed the heterogeneity in labeling, in using the terms, in dissections, and the entire heterogeneity among surgeons, among units, from the very same surgeon with different patients, with different time of his skill and excellence. So we've seen the heterogeneity of lymph node issue in Whipples, but we could get some good points. These are the important notes that we have to take it up, and we have to label it whenever it is possible. And I think the practical issues have been very well covered. And over to you, sir, for the final concluding remarks.
No, I think we just have 1 more minute. I have nothing more to say about Ashwini and Mahendra, but I'm very happy to see Harjeet maturing into a pancreatic surgeon, and credit to some extent probably goes to TD, and thank you, TD, for promoting him, for recommending him. Mahendra, you want to say something? You are muted. Unmute karo.
I just wanted to thank you for in believing me, and so far people only remember me as a bariatric surgeon.
You presented yourself as a bariatric surgeon. You whole presentation 20 times you said I do bariatric. So don't blame others. You are to be blamed.
So thank you for allowing me to present this.
Thank you.
First pancreas, whatever I have done, I just shown you. And once again, and
thank you. So we started at 7, we are at 9, so we will close. And I would like to thank Arun for accepting to moderate, because I had some personal commitments in between. And thanks to Ashwini, Mahendra, and Harjeet for presenting. Thank you, Dr. Sitaram, for once again being present throughout the masterclass. We hope to see you in all masterclasses and give your words of wisdom to all the young surgeons and students. Thank you, TD. Thank you.
Thank you,
We will close the session. And thanks to Avinash's team in Ahmedabad for providing all the technical support. And they have been religiously recording and putting all these videos. And I have to say that although the live attendance is not very high, but by tomorrow morning, we will have hundreds of views of these videos. And some of the masterclass videos, including the one on bile duct injury, are almost reaching 1,000 views. So I'm very happy that all the efforts put in by everybody are being used by students and practicing surgeons. Thank you all very much. Good night.
Thanks
Thank
a
you,
lot.
sir.